Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 234 of our pharmacotherapy series, which majors in respiratory tract infections. The first question reads, MPL is a 71-year-old man admitted to the hospital for a deep vein thrombosis. His past medical history is significant for chronic kidney disease with a creatinine clearance of 40 ml per minute, diabetes mellitus, COPD, GARD, hypertension, and a recent diagnosis of non-small cell lung cancer for which he is not currently receiving chemotherapy. MPL's home medications include lisinopril, famotidine, aspirin, insulin glargine, insulin aspart, tiotropium, fluticasone with salmeterol, and as needed albuterol. What characteristics does MPL exhibit that place him at risk for hospital-acquired pneumonia? Several risk factors for hospital-acquired pneumonia have been identified, including intubation and mechanical ventilation, aspiration, a patient's body position, the administration of enteral feeding, prior use of antibacterial agents, gastrointestinal bleeding prophylaxis, i.e., the use of histamine type 2 antagonists and proton pump inhibitors, immunosuppressive therapy, and poor nutrition status or glucose control. Other non-modifiable risk factors associated with developing hospital-acquired pneumonia include age older than 70 years and chronic lung disease. An important factor in the cause of pneumonia is colonization of the oropharynx, common in alcoholism and with prolonged hospitalization, and previous antimicrobial exposure. Several factors may contribute to the colonization of MPL's oropharynx with gram-negative bacteria. In addition to his pulmonary disease, an altered immune response in diabetics and the elderly can predispose MPL to respiratory infection. The use of drugs that inhibit the production of gastric acid, such as famotidine and omeprazole, increases the possibility of oropharyngeal colonization and pneumonia, yet acid-suppressive medications are commonly used to prevent gastric stress ulcers in mechanically ventilated patients. 3 days after admission, while receiving anticoagulation for the deep vein thrombosis, MPL exhibits a fever to 39.3 degrees Celsius. Antibiotics were inappropriately delayed, and over the next 24 hours, his respiratory function declined significantly, requiring intubation, PaO2 to FiO2 ratio of 250. Additionally, objective findings showed elevated WBC count, that is 17,200 cells per microliter, left shift, with immature leukocytes, bands amounting to 18%, and a new infiltrate on his daily chest radiograph. Sputum cultures are sent, and the decision is made to start MPL on antibiotics. So my question to you is, how should antimicrobial therapy be managed for MPL? because delays in the administration of appropriate therapy have been associated with increased hospital mortality from hospital-acquired pneumonia, the prompt administration of empiric therapy is essential. Importantly, changing therapy once culture results are available may not reduce the excess risk of hospital mortality if inappropriate initial therapy is selected. To this end, local bacteriologic patterns and in vitro susceptibility data should be made available and updated as frequently as possible to allow for appropriate selection of initial empirical therapy. In addition to the selection of an appropriate agent, the selection of adequate dosing regimens will optimize the pharmacodynamic properties of the antibacterial agents and improve clinical outcomes and mortality rates. Resolution of hospital-acquired pneumonia can be defined both clinically and microbiologically. Clinical improvement usually is apparent after the first 48 to 72 hours of therapy. During this time, the selected antibacterial regimen should not be changed unless progressive deterioration takes place or microbiologic studies confirm the pathogen. If culture results are negative or inconclusive because of known specimen contamination with mouth flora, the patient's response to the initial antibiotic therapy should be used to evaluate modification of the antibiotic regimen. If the patient responds to the initial regimen, consideration should be given to narrowing coverage to the most likely causative pathogens. If the patient is not responding to the initial antibiotic therapy, one should consider whether a. the pathogen is not covered in the initial choice of antibiotic therapy, b. the dose of antibiotic is insufficient, and c. any other factors are responsible for the failure to respond to therapy. Such factors include poor pulmonary clearance of necrotic tissue and cellular debris, lung abscesses or empyema, and severely altered host defenses leading to a rapidly fatal underlying disease. Of note, if one of the following organisms is isolated, Serratia, Pseudomonas, indole-positive Proteus, Citrobacter, or Enterobacter species, in vitro reports indicating susceptibility should be carefully evaluated, as these organisms often possess an inducible beta-lactamase gene, also referred to as a type 1 beta-lactamase enzyme. In vitro testing may demonstrate susceptibility to third-generation cephalosporins and extended-spectrum penicillins, but this may not translate into efficacy in the clinical setting. As a possible scenario of infection with these organisms, after initiation with one of the above agents, the patient may initially respond. However, after approximately 1 week, the patient's condition begins to worsen. Because treatment with the beta-lactam agent induces the expression of the type 1 enzyme, a subsequent sputum specimen sent after approximately 1 week is now likely to demonstrate resistance to the third-generation cephalosporins and extended-spectrum penicillins. Although cefepime is more likely to be active against these isolates, a large inoculum of organisms, e.g., that present in pneumonia, can result in beta-lactamase degradation of this agent as well. Considering that this phenomenon will not be identified by using usual in vitro testing, cefepime should be used cautiously in these patients. The preferred therapy in these patients includes trimethoprim sulfamethoxazole, a fluoroquinolone, or a carbapenem. Acinetobacter species are increasingly resistant to many commonly used antibacterial agents. Treatment of this often multiply-resistant pathogen requires the use of very high doses of ampicillin sulbactam, dosed at up to 24 grams per day, or colistin. The next question reads, 72 hours after empiric antibiotics were initiated, the microbiology laboratory reports that greater than 100,000 colonies per milliliter of MRSA have grown on MPL's sputum culture. Antibiotics are de-escalated to vancomycin therapy alone, to which the isolate is susceptible. After a loading dose and aggressive maintenance regimen, vancomycin trough concentrations have been 17 to 22 micrograms per milliliter. However, MPL remains febrile, demonstrates progression of his infiltrates on chest radiograph, and has acute worsening of renal function requiring dialysis and necessitating vancomycin dose adjustment. Repeat tracheal cultures again grow only Staphylococcus aureus with susceptibility to vancomycin, sulfamethoxazole trimethoprim, daptomycin, and linezolid. So my question to you is, should MPL's antibiotic therapy be modified? Regarding vancomycin, the recommended dosing of IV vancomycin is 15 to 20 mg per kilogram per dose, basing on actual body weight, every 8 to 12 hours, not to exceed 2 grams per dose, for patients with normal renal function. A loading dose of 25 to 30 mg per kilogram, basing on actual body weight, may be considered. Some patients may experience an adverse event during the infusion of vancomycin known as red man syndrome. Extending the infusion time to 2 hours for larger doses or premedicating patients who have experienced this phenomenon with an antihistamine may alleviate this adverse event. Vancomycin trough concentrations of 15 to 20 micrograms per milliliter are recommended for the treatment of pneumonia, as higher trough serum concentrations should increase the likelihood of optimizing the area under the curve (AUC) and minimum inhibitory concentration (MIC), and, therefore, take into account higher vancomycin MIC values appreciated in some isolates. It has also been postulated that targeting higher trough values may help to overcome vancomycin's inherent impaired penetration into epithelial lining fluid and respiratory secretions. Of note, there are no data confirming that achievement of more aggressive trough levels is associated with improvement in clinical cure. Next we will discuss linezolid. Linezolid achieves higher concentrations in lung epithelial fluid than in plasma and serves as an alternative to vancomycin for the treatment of MRSA pneumonia. A retrospective analysis of 2 prospective trials for the treatment of hospital-acquired pneumonia found that patients in the subgroup of MRSA cases randomly assigned to linezolid experienced higher cure rates and lower mortality compared with vancomycin. In contrast, a meta-analysis of 8 randomized controlled trials comparing glycopeptide antibiotics to linezolid for suspected MRSA pneumonia found no evidence to support superiority of linezolid. The ZEPHYR study compared linezolid with vancomycin in patients with proven nosocomial MRSA pneumonia in a randomized, double-blind fashion. This is the largest trial conducted in this population to date, and it showed a statistical improvement with linezolid in clinical outcomes at the end of study, yet the confidence interval was close to no significance and only showed a benefit with linezolid in identified nosocomial MRSA pneumonia. These results make it difficult for initial selection over vancomycin for empiric therapy of MRSA coverage. Therefore, it remains uncertain whether linezolid or vancomycin should be considered superior. MPL is at risk for MDR pathogens due to current hospitalization of 5 days or more and immunosuppressive diseases, and should be started empirically with an anti-MRSA agent, such as vancomycin, and double coverage for resistant gram-negative pathogens with cefepime and gentamicin or ciprofloxacin. Dosing and frequency of antimicrobial agents will require renal adjustments because of MPL's chronic renal issues. When culture results are known, the antibiotic regimen can be modified and individualized. For patients with uncomplicated hospital-acquired pneumonia or ventilator-associated pneumonia, who have received appropriate empiric antibiotics with a satisfactory subsequent clinical response, 7 to 10 days of therapy is recommended. However, patients infected with non-fermenting gram-negative bacilli, i.e., Pseudomonas and Acinetobacter, may benefit from longer courses lasting 14 days or greater, to prevent recurrence. MPL's clinical response should be monitored to determine whether the selected antibiotics are effective in treating this infection. These parameters include the ability to discontinue mechanical intubation and decreases in temperature and WBC count with resolution of the left shift. Since MPL remains febrile despite MRSA sensitivities to vancomycin with appropriate trough concentrations, it is appropriate to consider alternative MRSA coverage. Despite MRSA susceptibility to daptomycin, the drug does not penetrate lung surfactant, and therefore it is not appropriate to use in the treatment of pneumonia. Sulfamethoxazole trimethoprim is a less appealing option owing to the patient's dialysis requirement. MPL should be switched to linezolid. Linezolid quickly reaches high lung concentrations and is safe to use in the setting of acute renal failure. Linezolid has been associated with thrombocytopenia and neutropenia. Platelet counts and WBC should be monitored at baseline and at least every 7 days during treatment. Let's now consider alternative agents. Doxycycline, clindamycin, and sulfamethoxazole trimethoprim are not reliably active against MRSA strains, and recent research has focused on novel agents. Although active against MRSA, tigecycline has been associated with worsened clinical outcomes when used for the treatment of hospital-acquired pneumonia, including MRSA pneumonia. Telavancin has been compared with vancomycin in the treatment of hospital-acquired pneumonia caused by gram-positive pathogens. Treatment with telavancin achieved higher clinical cure rates in patients with monomicrobial Staphylococcus aureus infection and in those with isolates that demonstrated a vancomycin MIC of at least 1 microgram per milliliter. However, lower cure rates were observed in the telavancin group in those who had mixed infections. Telavancin use was also associated with a higher incidence in serum creatinine elevation, yet the drug was approved by the U.S. Food and Drug Administration in 2013 for hospital-acquired pneumonia when other alternatives are not suitable. We will now discuss aminoglycosides. Individualization of aminoglycoside dosing is imperative as the therapeutic outcome, that is efficacy and toxicity, of aminoglycosides correlates with plasma concentrations in patients with gram-negative pneumonia. In patients receiving multiple daily doses of gentamicin or tobramycin and achieving a 1-hour post-infusion peak plasma concentration of greater than 7 micrograms per milliliter, a successful outcome occurs more often than in those with lower plasma concentrations. The aminoglycosides are concentration-dependent killing antibiotics. The rate and extent of killing organisms is maximized by increasing their peak serum concentration relative to the MIC of the pathogen. In addition to maximizing bactericidal activity, in vitro evidence has demonstrated that this concentration goal also minimizes the development of resistance. The use of once-daily dosing strategies to minimize nephrotoxicity of the aminoglycosides has been studied extensively. Single doses of gentamicin and tobramycin, dosed at 5 to 7 mg per kilogram per day, and of amikacin dosed at 15 to 20 mg per kilogram per day, have been reported to be as effective as standard dosing, smaller single doses given every 8 or every 12 hours, of these agents in controlled clinical trials. However, none of the trials has enrolled a sufficient number of patients required to demonstrate a lower incidence of nephrotoxicity. There are several advantages of once-daily dose aminoglycoside therapy. A. It is no more nephrotoxic than traditional dosing. B. Clinicians are ensured that a therapeutic peak serum level will be achieved with the first dose. C. It is the only safe and effective way to achieve serum peak levels of 10 to 20 times the MIC for difficult-to-treat organisms such as Pseudomonas aeruginosa, and D. It is a more efficient dosing regimen, fewer doses and administration times per day, fewer serum level measurements are required. Despite the use of individualized aminoglycoside dosing, morbidity and mortality rates attributable to gram-negative pneumonia remain high. This is because the success of antibiotic therapy depends on the ability of the antibiotic to reach the site of infection and remain biologically active. Concentrations of the aminoglycosides in bronchial secretions range from 1 to 5 micrograms per milliliter, that is 30% to 40% of serum concentrations, 2 to 4 hours after parenteral administration. These concentrations may be insufficient to inhibit the growth of many gram-negative organisms, especially Pseudomonas. Lastly, aminoglycosides bind to purulent exudates and cellular debris and are inactivated by these agents. In summary, the aminoglycosides penetrate poorly into bronchial secretions and are less active at the site of infection because of local pH effects and binding to cellular debris. These properties may result in the need for increased dosages, placing patients at increased risk for ototoxicity and nephrotoxicity. Therefore, unless no reasonable alternative exists, aminoglycoside monotherapy for the treatment of pneumonia should be avoided. And now we will discuss inhaled agents for multidrug-resistant pathogens. Because of the growing incidence of pneumonia caused by MDR gram-negative organisms, interest has been renewed in the use of inhaled aminoglycosides and polymyxin products. When given systemically, both classes have been associated with poor pulmonary penetration and with nephrotoxicity, with polymyxin carrying the additional risk of neurotoxicity, and with aminoglycosides ototoxicity. However, the proposed high drug concentrations at the site of pulmonary infection, minimal systemic exposure after nebulized administration, and data showing benefit in both the prevention and treatment of Pseudomonas pulmonary infection in cystic fibrosis patients make aerosolized antibiotic therapy an appealing strategy for the treatment of ventilator-associated pneumonia. The IDSA/ATS guidelines state that aerosolized antimicrobials may be considered in patients with MDR organisms not responding well to IV therapy. The use of adjunctive inhaled antibiotics in ventilator-associated pneumonia has been evaluated in several studies. A systematic review of 16 observational studies and randomized trials without blinding revealed that aerosolized colistin was associated with microbial eradication odds ratio 1.61, with a 95% confidence interval of 1.11 to 2.35, and improved clinical response odds ratio 1.57, with a 95% confidence interval of 1.14 to 2.15, but the results were limited by several biases. A systematic review of 12 observational and randomized trials with some blinding showed that nebulized antibiotics in patients with ventilator-associated pneumonia had some benefit in patient outcomes. Nebulized antibiotics were associated with increased rate of clinical cure, risk reduction, 1.23, with a 95% confidence interval of 1.05 to 1.43. Neither studies showed an improvement in mortality, duration of mechanical ventilation, or length of stay in the intensive care unit. We will now describe alternative dosing of antibiotics for multidrug-resistant pathogens. Carbapenems, cephalosporins, and extended-spectrum penicillins or beta-lactamase inhibitors demonstrate time-dependent killing, and it is known that bactericidal killing for these drug classes is optimized if their free drug concentrations are greater than the MIC 30% to 40%, 50% to 60%, and 60% to 70% of the time, respectively. Prolonged or continuous infusions have been used to increase the time that free drug concentrations are greater than the MIC, theoretically leading to improved patient outcomes. Continuous infusions were first used in the late 1970s with suggested improvement in clinical cure rates, but until recently they were largely abandoned owing to logistical concerns about medication stability, drug compatibility, and limited IV access. These concerns were lessened by use of contemporary prolonged infusions. This latter strategy is supported primarily by Monte Carlo simulation, a mathematical modeling technique that estimates the probability of pharmacodynamic target attainment at each MIC for a given MIC range. Patients diagnosed with ventilator-associated pneumonia and treated with cefepime, dosed at 2 grams every 8 hours for 3 hours, have been evaluated using Monte Carlo methodology. Investigators found that at an MIC of 1 microgram per milliliter, all regimens had a probability of target attainment greater than 90%. However, at an MIC of 8 micrograms per milliliter, when compared with 30-minute intermittent infusions of 1 to 2 grams every 8 hours and 2 grams every 12 hours, only the prolonged infusion, that is over 3 hours, of 2 grams every 8 hours maintained 90% probability of target attainment. As one might predict, this phenomenon was only demonstrated in patients with preserved renal function as defined as a creatinine clearance of 50 to 120 milliliters per minute. Intermittent and continuous infusion dosing strategies have also been compared when using piperacillin tazobactam to treat Pseudomonas infections. Ladais and colleagues retrospectively compared intermittent infusions of 3.375 grams IV piperacillin tazobactam infused over 30 minutes every 6 hours versus extended infusions of 3.375 grams IV piperacillin tazobactam infused over 4 hours every 8 hours. Results indicated a shorter length of hospital stay, 21 days versus 38 days, with a p-value equal to 0.02, and lower 14-day mortality rate among patients with acute physiological and chronic health evaluation 2 scores greater than 17, that is 12.2% versus 31.6%, with a p-value equal to 0.04 in patients receiving extended infusion therapy. We will now briefly talk about ventilator-associated pneumonia prophylaxis. The substantial risk of pneumonia in the ICU has prompted aggressive methods to prevent this disease. The most important recommendations include the use of the semi-upright position to reduce the risk of aspiration, infection control including hand washing to prevent the spread of pathogens from one patient to the next, and surveillance for ICU infections. Several strategies for prevention of ventilator-associated pneumonia are controversial, including selective decontamination of the digestive tract, abbreviated as SDD, selective oral decontamination, abbreviated as SOD, and topical antiseptics applied to the oral mucosa. These 3 strategies address the concept that ventilator-associated pneumonia occurs after colonization of the upper respiratory tract. Because digestive tract flora may play a role in this colonization, the impact of various decontamination approaches has been studied. For SDD, a combination therapy including topical tobramycin, polymyxin E, and sometimes amphotericin B is administered to the stomach and oropharynx 4 times daily in combination with IV administration of ciprofloxacin or a second-generation cephalosporin. SOD uses a similar antimicrobial strategy to SDD, except that the IV agents are omitted and the combination therapy is applied to the oropharynx. Historically, SDD and SOD are more widely used in Europe, and most of the literature investigating these techniques in thousands of patients and supporting their use results from outside the United States. In 2009, de Smet and colleagues performed a large crossover study comparing standard of care ventilation bundles versus SDD versus SOD in mechanically ventilated patients and found a statistically reduced risk of 28-day mortality with an odds ratio of 0.83, with a 95% confidence interval of 0.72 to 0.97 for SDD and 0.86 with a 95% confidence interval of 0.74 to 0.99 for SOD. In 2015, Roquilly et al. Produced the largest meta-analysis of ventilator-associated pneumonia prevention techniques to decrease mortality. Over 37,000 patients were involved from 157 randomized trials. Although the overall mortality reduction was 5% in the intervention group, in a subgroup analysis, only SDD significantly decreased mortality compared to control with a risk reduction of 0.84, with a 95% confidence interval of 0.76 to 0.92. Despite the overwhelming evidence supporting SDD, leading clinicians suggest there are still concerns of North American practitioners who fear that widespread use of antibiotics for SDD will increase antibiotic resistance and Clostridioides difficile infections, particularly in the United States where drug resistance is more prevalent than in Northern Europe. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 235.